Yes, I presented him about a week ago for preoperative conference. 59-year-old computer program with progressive myelopathy, including loss of balance, difficulty with fine motor skills in his bilateral upper extremities, which is important to him as he's a computer programmer and he plays guitar. Multiple falls. I really had a 5-year course, which really started with radiculopathy and paresthesias in his left radial hand. They subsequently extended to encompass his entire hand over the last 2 years. And then he started having his myelopathic issues. Other spine surgeons, both of whom recommended surgical intervention. He presented for a third opinion. He's very worried about potential loss of motion with fusion procedures. Concerningly, he noted a recent episode in which he experienced entire body warmth and numbness throughout his entire body after a coughing fit. He notes the symptoms lasted about 30 seconds before he returned to his normal steady state. Exam prior to surgery, he had basically some weakness in his hand grip and intrinsics on the left, and then decreased sensation basically through his entire left hand. He also started to note some decreased sensation in his right thumb in the C6 distribution. Flexic with positive Hoffman's bilaterally, 4+ reflexes throughout his upper and lower extremities, sustained clonus on his, in his left lower extremity, and 3 to 4 beats on the right. Multi-level spondylotic changes from C4 to essentially C7, with really the worst disc-based collapse and osteophyte formations at C4-5.
Oh, there you go.
At 4-5, the patient has severe central canal stenosis with cord signal change at that level. At the C5-6 and 6-7 levels, he has bilateral neuroforaminal stenosis, worse on the left, but not any significant central canal stenosis. Below that, he's fine. So, long talk with this gentleman about various options. Basically, as his previous surgeons had recommended, we recommended that from 4 to 5 at the very least, he needs to have that taken care of with a fusion type procedure in order to stabilize, both decompress and stabilize the spine. That were discussed were basically what to do about the 5, 6, and 6, 7 levels. Because the patient's initial symptoms started with left hand problems, we were not able to rule out, which symptoms came from myelopathy and which were from radiculopathy on that side. And so we recommended treating those at the same time in order to address those issues.
Hey Dan, was it just issues with hand dexterity? Did he have any issues with classic upper extremity radicular pain, like lancinating pain, or is it just hand dexterity and strength?
Pain. So he had pain and numbness, which kind of 5 years earlier had started in his kind of C6 distribution on the left, and then kind of extended to kind of his whole hand over time. And it really was only in the last year or so that he started having this progressive myelopathy. So we weren't really able to reliably differentiate between, what's myelopathy, because his imaging was only recent. So what's truly myelopathy and what may have been radiculopathy before that myelopathy. So given the patient's, concern about stiffness and his kind of reluctance to undergo surgery, we actually talked to him about just doing a 4-5 ACDF and leaving the foraminotomies alone. We've kind of recommended against that because he'd have a reasonably high likelihood of still having symptoms afterwards, and it would be hard to know whether those were from residual compression versus, just residual symptoms from his myelopathy.
How old again, Dan? Sorry.
Reasonably youthful guy, no other major medical issues. So
I'm sorry, how old did you say? I think it cut out.
59.
59.
A prior surgeon had recommended had talked to him about doing a posterior laminectomy infusion at 4-5 and then foraminotomies below that. We talked to him about doing a 3-level ACDF, which was our preferred surgery, but then offered, if he was really worried about this potential stiffness from that, to do a ACDF of that side, then flip him and do foraminotomies on the left. As being a potential viable option. He went home and thought about it for a long time and ultimately concluded that the 4-7 ACDF was in his best interest.
I agree with that. I mean, it's easy to overthink it sometimes.
Showed him when we were talking about it is we did measurements from 4 to 7 and basically showed him that there was really only like 10 degrees of motion at those levels between flexion and extension. So the motion that he's worried about losing, he's kind of already lost it. So that kind of gave him a sense that, there was a little less to lose in terms of his neck range of motion.
And you can give him a nice alignment too with that anterior construct.
Levels, he's lost his lordosis. So those were kind of our main arguments, and ultimately he decided to do that. So we ended up doing a 4 to 7 ACDF. These are our x-rays here. We were pretty happy with the results, and he actually woke up feeling great. He felt like his numbness was a little bit better. He got up and walked around that night and felt like his balance was maybe a little bit better. And then the next morning I came and saw him, and at about 4:30 that morning, he had started to have a C5 palsy on his right side where he had no symptoms before. So he had about 20-hour delayed post-operative right C5 palsy. He was about 3 out of 5 strength in the biceps and the deltoid, no paresthesias, so just motor weakness. I just put together this little talk on post-op C5 palsy. Basically, it's been defined in a lot of different ways, but I thought just kind of characterizing it based on this review I read, it has some de novo. It basically is defined by de novo muscle weakness in the C5 region, although it has been occasionally described in patients that have it in other nearby regions. People will still call it a C5 palsy because it's so common. There's some sensory disturbance or dysesthesia in about half of patients. 92% of patients, it's only hemilateral. It almost always occurs within 1 week of surgery. And there has been, this is a controversial statement because multiple authors have found differing things, but in all of the meta-analyses and systemic reviews of this, there's been basically the same incidence between anterior and posterior approaches. There's relatively good prognosis, even in those with severe muscle weakness, but they do have longer recovery time. So there's kind of 2 main theoretical causes for this, and it has yet to be determined exactly what causes it. The most likely cause is traction injury to the anterior motor root. It's been theorized that this might be from the posterolateral corner of the vertebral body, which Keegan in 1965 called the high spot. This, has been dubbed the nerve root injury theory. C5 has the shortest distance between the division from the dura to the foramen of all the brachial plexus nerves. Its anterior rootlets run adjacent to the narrowest part of the foramen, and the other theory is that the distance from the dorsal ramus to the medial branches is the shortest for C4 and 5. That innervates the multifidus, and retraction of that during posterior exposures may actually kind of hinder free movement of the nerve root during manipulation and stretching. So it's also been proposed there may be a vascular disturbance to the anterior horn cells, or the segmental spinal cord disorder theory, and that this may be secondary to an ischemia or reperfusion injury following decompression of the cord. Just published in 2017, there was a retrospective review of about 14,000 patients undergoing subaxial cervical spine surgery across 21 centers through the AO Spine database. They identified 59 cases of documented C5 palsy, with an incidence of 0 to 2.5%, depending on center. At their most recent follow-up, about a little more than half of patients noted complete resolution of symptoms, 25% had partial resolution of symptoms, and 17% reported no recovery. They lost a couple percent to follow-up. The onset of palsy almost always happens in the first week, usually in the first day, but it's not uncommon for it to happen in the second and third day as well. Time to resolution, it typically seems to happen in the first 3 to 6 months. Although you can see even at the 12-month mark, they had 8 patients out of those 59 who did not resolve until almost a year out. So that's an interesting thing to note with your patients when you're following this. Most of the patients who had a C5 palsy had cervical spondylotic myelopathy. Half when you count all the different issues here together. And then they found that a large proportion of the patients who had this injury in that database were from a posterior fusion, not an anterior fusion. Tough to really differentiate whether that's because of the approach or whether it's because the posterior fusion patients were more likely to be undergoing surgery for spondylotic cervical myelopathy, which is already a known risk factor. So it's hard to read into that too much, but that's just kind of an epidemiology of C5 palsy paper that hasn't really been well described until recently. We'll see how this gentleman does. We told him he has a reasonably high likelihood of getting a full recovery, and in the meantime, we're going to work with him on physical therapy. We gave him an extra 24 hours of steroids without a great evidence basis for doing it, but it certainly made me feel better to potentially take some inflammation off of that nerve.
What else, Dan? Did you get any imaging or?
I think at this point the EMG is not going to show anything, sort of like with nerve root avulsion, Hey, how weak is the guy? What out of 5?
Like 3 out of 5. He didn't have a dropped shoulder, but he was weak.
Yeah, they usually get better by 12 to 24 weeks. Gosh, I saw this one guy that came down from LA. He had surgery at Cedars, and he had complete bilateral C5 palsies. It was one of the most frightening things ever. I mean, the guy couldn't do anything, couldn't feed himself.
Yeah,
it's horrible.
Hey Dan, I guess the group, do you guys get like a CT scan afterwards? Make sure the framing is okay. I had one. I've had 2 since I started. The first 2 years in practice, I was 0, and then I've had 2 in the last 6 months, both from ACDFs. So I get a CT scan. The first one got better completely. The second one is still pretty fresh. He's less than a month out. I got a CT scan in both just to make sure there's nothing in the framing. I mean, is there anything? I'll get an EMG at 3 weeks or so just to make sure there's not active denervation. Is there anything else you guys do as part of your sort of evaluation and workup?
I think that's it. If they're weak, I get a CT and an MRI just to make sure there's nothing going on. No chunk of bone or something in the foramen or canal. And then it's just like steroids and reassurance.
Yeah.
So handy for me, it also depends on which approach I use. So if I use the posterior approach, where you really unzip things and totally open everything up, that I'm way more confident that the palsy is what it is. You know what I mean?
Yeah.
Versus an anterior approach where sometimes it's well, did I get that foramen open enough that I dissected it?
Yeah.
You know what I mean? It's that piece might change it. The other thing is the only other place I would say just be careful is in realignment surgery. When you're changing the lordosis substantially, you can actually be clamping down on that foramen. That may require advanced imaging just to see if you need to actually loosen things up. And if you did a posterior approach only, you may want to go back in and do an anterior approach to open things up.
Yeah.
So there's those kind of things I think are probably relevant.
In this most recent case, there's a 4-5 with a significant slip and myelopathy and some myelomalacia at that level. And so I reduced the slip just from anteriorly and also putting a pretty lordotic cage. And the CT scan looks fine, but I just wonder if that that movement is putting a lot of traction on that super sensitive root. So CT looked fine. I'm going to get an EMG and just kind of hope for the best. But it's one of the hardest things, Dan and Rob, especially early in your career. I think you're so sensitive to anything not going well that you want to fix it right away. Like your immediate instinct as a surgeon is to want to fix the problem. And this is one of the ones that you have to ride out for the most part. And it's just, it goes against your nature as a surgeon to
not.
Man. Yeah, just to be like, hey, it's gonna be fine. I'm not gonna fix it. It's gonna fix itself. I don't know if it's a personality thing or most surgeons are like that, but
yeah, we published a paper a few years ago from our experience at Sharp, and we noted that patients that had a lot of intraoperative C5 firing were more likely to have a C5 palsy. And so it's almost one of those preventative things. So patients are demonstrating that during surgery, you can do a little bit more of an aggressive foraminotomy. Not that it's all telling, but it's helpful.
Yeah.
Hey, Dan, what was the sequence of levels that you did?
Off the top of my head, for him, I believe 5, and went down from there.
You started at 4 or 5? Hello?
I'm here. Can you hear me?
Yeah. You guys started at what level?
At 4 or 5, if I'm recalling correctly.
Okay.
Yeah.
All right. So like just good. But like I learned something from Hanny's mentor this last weekend in Vail, which was like, he said, anytime he's doing any multi-level ACDFs, that includes 4 or 5, he always does 4 or 5 first, period.
Yeah. Yeah.
And the main reason is that he fears that if you stuff the implant above and below it, that it will actually put undue pressure on the 4 or 5 level and then cause, even if it's temporary, like stenotic, make the foramen more stenotic. So he basically says, listen, do 4 or 5 first. Make sure you get that foramen open. Make sure you, and he says he doesn't overstuff any other interbody space, but he overstuffs 4 or 5. He wants to make sure that foramen is wide open. So I just thought that was an interesting concept because I hadn't really thought about that. A lot of times I think about, like if I'm doing a 3 to 7, I think about doing 6, 7 first because it's the furthest down. And it's going to be, if I put 4, 5, 5, 6 in, then I'll have, I'm pushing 6, 7 further away, basically, is kind of my thought. And it may be harder to get in there, especially if I make the neck more lordotic. So, but this concept of saying, listen, always do 4 or 5 first because it's the highest risk for C5 palsy, it probably makes more sense.
And how many of you guys are doing prophylactic foraminotomies when you're doing it posterior?
I do it every time bilaterally, and that's another Trinellis thing. He like is obsessed with it. I think probably because he's such a talented guy, he has so few complications. That's the one that's kind of hard to technically mitigate, and so he does it all the time. I do it as well. It doesn't take a lot of time, and then God forbid, especially if it's like a case where the cord is going to drift back and there's going to be some stretch on the roots. At least then you did it, and
Yeah, I decompress the foramen every time.